Good evening, everybody. My name is Jeroen van Moorselaar, and very much welcome to the webinar on surgery or radiotherapy for locally advanced prostate cancer. I must say hello Europe, and we have had that in Rotterdam last weekend. It was the Eurovision Song Contest, and this is also a very big happening. We have now about 1,000 participants. It's amazing, 1,000 people listening to us. But we'll try to make a nice evening for you for 1 hour only. I must show you my conflicts of interest, of course. These are the speakers for tonight. Is Professor Alberto Bossi. He is from France, from Paris, but we just talked about it. He is also from Italy and also from Belgium, so he's the real European. And he is a radiation oncologist. And Michiel Sedelaar, urologist from one of the biggest departments in the Netherlands, from Nijmegen, and myself, I'm Jeroen van Moorselaar. Short introduction, then radiotherapy with or without hormonal treatment for locally advanced, then radical prostatectomy for locally advanced cancer, and then I'm going to talk about adjuvant therapies after radical prostatectomy. This is the world and highlighted Europe. And we know, of course, that the incidence of prostate cancer is the highest in a lot of European countries. In the East is still the highest as lung cancer, but in most countries it's prostate cancer. There's one yellow dot that's colorectal cancer in Slovakia. And the mortality is still highest for lung cancer, except for Sweden. And this is important, of course, that we find many more prostate cancers than we treat, and the mortality is much lower than what we find. So we really have to make choices which patient we shall treat, and that is for tonight one of the lead items. The relative survival of localized and regional, so that's locally advanced, is very good, but we have to be very careful that once that locally advanced cancer becomes metastatic, then the survival is much less. So we have to know which patient we should treat, and that's what we're going to talk about tonight. So what's the best? Radiotherapy or radical prostatectomy? Of course, I'm a urologist, I would say radical prostatectomy, but we are not sure. We are not sure. And there is one randomized trial going on in the Scandinavian countries, and it might be that that will give us the answer, but we really don't know yet. We will ask the speakers about that. So what's the webinar about? 50 minutes per presenter. Then we have 5 minutes for questions after each presentation, and you can ask your questions through the question portal, the Q&A or the chat function. And you get, when you're still, after 1 hour there, you get 1 CME point. So far, my slight introduction, and I will turn over the word to Professor Bossi. You're going to share your screen, I hope.
Yeah, here it is.
And you're going to talk about radiotherapy on hormones and then specifically for T3. The floor is yours, Alberto.
Thank you, Jeroen, and thank you for inviting me in this interesting evening. So radiotherapy and hormones for high-risk prostate cancer. I have also a list of conflict of interest, which I have to declare here. Nothing of those has to do with what I will tell you tonight. So I guess I am speaking to a group of urologists in front of me, and what we very often we ask we the radiotherapists is we have the impression that urologists do not like that much radiotherapy for prostate cancer, and there may be a lot of reasons that you can find here on the left hand side of my slide, which are not all so trivial ones. I will try to go through some of them in my next 15 minutes to discuss the importance of radiotherapy and hormones in the treatment of prostate cancer. So, first point I want to make, what do we know in terms of radiotherapy for high-risk prostate cancer? We have a list of very important points that have been established in the last 20 to 25 years by randomized clinical trials, so evidence-based medicine. First of all, we need high prostate dose if you want to achieve a good local control. There is a dose-response relationship in prostate cancer. The more dose you give into the prostate, the better result you have. And this independent of the technique you are using. IMRT, IGRT, stereotactic body radiotherapy, using a boost with low dose rate, high dose rate, brachytherapy, as it has been the case in the ASCEND radiotherapy trial. Whatever technique you use, you have to go for high dose into the prostate. Second point, we know that radiotherapy plus hormones yield better result than radiotherapy alone. I'm sure I don't have to make a long story about trials that have been published in the last 30 years looking at these specific items. You have here a list of the most important ones. There are old trials. You may know the very famous, for us, the European Michel Bollard URTC trial. You can see that altogether, more than 4,000 patients have been randomized in the last 20 years on this specific question. Is radiotherapy alone a good choice, or isn't radiotherapy plus hormones a better choice for the treatment of high-risk prostate cancer? And all randomized evidence goes in the same direction. You need hormones together with radiotherapy to get the best result. And you may recognize here that for us, European, the URTC trial has set the standard of care, which is 3 years androgen deprivation therapy. The American RTOG trials would go probably for 2 years androgen deprivation therapy. And more recently, we have studies showing that 18 months may be enough. But altogether, these go to the direction of showing us that hormones together with radiotherapy gives better result than radiotherapy alone. Third point I want to make, again from randomized evidence, we also know that radiotherapy plus hormones is better than hormones alone. And this is something that sometimes even the radiotherapy community tends to forget. Hormones alone is probably the worst choice for high-risk prostate cancer. We have randomized evidence, and this is probably the most important study with Malcolm Mason has been reviewing and publishing in 2015, which showed that in 1,200 patients, all high-risk disease, randomized between hormones alone or hormones plus radiotherapy at a median follow-up of 8 years, no doubts radiotherapy halved the risk of dying of prostate cancer when added to hormones. So no discussion, hormones alone is not a good choice for high-risk prostate cancer. You have to add some local control, in this case, with radiation therapy. So these are all hard results, which makes what we call evidence-based medicine, the top of the pyramids. But it's important to acknowledge that we have a list of questions in the field of radiotherapy for high-risk prostate cancer, which honestly, I don't know the answer for. I told you we need high total dose into the prostate, but I don't know which is the high total dose we need. 75, 78 gray, more than that, as you can achieve with a brachytherapy boost, no clear evidence or not clear endpoint which has been studied in this topic. I don't know which is the best technique. Stereotactic body radiotherapy is very interesting because it gives a lot of dose in few fractions, but probably a brachytherapy boost is also interesting. No randomized evidence up to now on this. I don't know how long these long-term hormones should be associated to radiotherapy. I told you we have evidence about 18 months in the states that prefer to use 2 years hormones. The standard of care established by Michel Bollard more than 20 years ago was 3 years older. So there is still some work to do in this field. And for us, the radiotherapists, it's only very recently that the first randomized trials was published on this question of about the treatment of the pelvic nodes. Should we have to treat the pelvic nodes or not? And then, of course, and I'm sure you are waiting for this, there is a $1 million question. Is radiotherapy better or not as compared to surgery? I don't have the final question of it. Even if I am a radiotherapist and I have this deep belief in what I'm doing, I have to honestly admit this is still a big question mark in our field. So whatever you will read about all these questions, and the last one specifically pertains to what we call evidence-based medicine. You have a lot of trials, a lot of observational data that have been published on these topics, but these, believe me, has not the same evidence, force of evidence as what I've showed you before. And this has to be taken into account when making comparison between different techniques. And if you look carefully in the literature, of course, you have a lot of studies showing that surgery is better than radiotherapy for high-risk prostate cancer, but you may also find studies like this one. Again, observational studies in which Gleason score 9 to 10 prostate cancer patients have been treated in very important American institutions, and there are some 2,000 patients with these very high-risk features. Some of them were treated with radical prostatectomy, associated eventually to radiotherapy. Some of them were treated with external beam radiotherapy alone, and some of them were treated with external beam radiotherapy plus a brachytherapy boost. And at the end of the day, if you just compare those population of patients, you may get this sort of results. You see that there is one curve which is doing quite better as compared to the other, and this curve is the one of the patients treated with external beam radiotherapy plus brachytherapy. Is this a final word? Not at all. Don't forget, this is very low evidence. This is just hypothesis generating, and it generates the hypothesis that the brachytherapy boost may be beneficial in this population of patients. But this is just to show you what you can find in the literature in terms of comparison of different techniques. And of course, as soon as you add different treatments, radiotherapy plus brachytherapy, you may find out that toxicity increase. And indeed, this is a very interesting paper which was published on European Urology in 2015, comparing the urinary adverse event risk in some population of patients treated with very different techniques. And you have two sort of very important messages here. First of all, you have a control population, the black line, the black curve here, which tells us that unfortunately age is associated with urinary adverse event independently of any treatment on your prostate cancer. And then you have some other curves here showing you that there is some risk of urinary adverse event as soon as you associate treatment. You see here that my curve with brachytherapy and external beam radiotherapy is up here. So you have a substantial risk of toxicity in terms of urinary adverse event after radiotherapy plus brachytherapy, but also radical prostatectomy when associated with post-op external beam radiotherapy may result in some form of urinary adverse event. And I think this is important to be aware of when exposing the different options to our patients. So my message here is that as soon as you are looking for the famous answer about what's best for your patient, you don't have to look to an observational data set. Firas Abdullah, which is a neurologist that you probably know, published this very interesting list of limitations that still you should take into account when comparing data set analysis. data set are unable to account for evolution of treatment modalities, makes it impossible to adjust for confounders, very rarely include details on salvage therapy, and of course suffer from lack of randomization. So this is a plea for not using observational data when comparing treatment. You are at risk to comparing oranges with apples, and this is not what we want to do for the benefit of our patients. Also because if you look with attention on what has been published, for example, using observational data set, and this group of the MD Anderson Cancer Center in Texas has done a very nice exercise. They have looked at the published result of different therapies for different sort of tumors. We are, of course, interested in prostate cancer results, and they find out that if you look carefully to your data, you will find out that patients who underwent radical prostatectomy for prostate cancer had better survival than a control population without cancer. Why is this? Well, because, of course, surgeons tend to select patients for radical prostatectomy, and they will pick up patients which are in very good general conditions. And this is also known as the John West phenomenon. John West sells fish. You can see here in the back, and he says that John West sells good fish because he rejects the bad ones, and he keeps only the good ones for him. And this is a little bit what happens when you compare in an observational set patients treated with radical prostatectomy versus radiotherapy. Some last words are devoted to hormonal therapy in this setting, because we have of course, this data that I showed you telling us that hormones are useful, are needed for the vast majority of those patients. The question is how modern therapy, radiotherapy, may impact on the need of hormones in those patients. You see that Michel Bollard himself was concluding his seminal article of 2002 saying that the contribution of radiotherapy on local control may be further improved. And this is what happened in history. So does this mean that at least for a subset of patients, even in the high-risk group, hormones may not be necessary? Well, if you look to the result of these curves here, you see that people treated with radiotherapy alone, a good proportion of them were still alive 8 to 10 years after the treatment. So this means that there may be a subset of patients for which a hormonal treatment is not necessary. And this is a little bit what happens also for surgery. You see here the famous impact experience with different high-risk prostate cancer patients treated with radical prostatectomy, but a group of them didn't relapse, even if they were treated with surgery alone. So my conclusion is that for those ones up here, local control by surgery in this case, by radiotherapy perhaps, is the dominant cause of survival. And probably for those, as surgery alone is good, high-dose radiotherapy alone may be enough. For those one down here, rapidly dying from prostate cancer, distant control of the disease is dominant. And don't forget, these are all high-risk prostate cancer. But apparently, high-risk prostate cancer is not an homogeneous group of patients. How to distinguish patients in the high-risk group? They may not need a long hormonal treatment. Probably genetic profiling may help us. Dan Spratt has done a very interesting job in trying to integrate genomic classifier in clinical pathology risk classifier to derive some more information in this heterogeneous group of patients. And this is his conclusion. You see here on the right-hand side that clinical and genomic factors may bring us a much more precise identification of what we are talking about when talking about high-risk disease. And his final conclusion is that maybe some of those patients do not need such long hormonal treatment when good radiotherapy is given. And this is a very nice representation of it. You have the same patient having high-risk features, T3 cancer, PSA 10 to 20, Gleason score 4+4. But on the left-hand side, you have low genetic characteristics. And on the right-hand side, you have high-risk genetic characteristics. The kind of treatment that you may apply for those patients may be totally different. On the left-hand side, unique treatment by surgery or radiotherapy alone may be enough. But on the right-hand side, you need to absolutely get a maximum in terms of association of treatment because the disease is much more aggressive than the one of the left-hand side. So we have probably today in 2021 the possibility to better define the kind of hormonal treatment you will need with radiotherapy in this respect. The last point I want to make is about second cancer, because this is, of course, an argument that has been used in order to tell patients, well, be careful because radiotherapy may give second cancer. And this is true. Radiation may give second cancer. Depending on the technique you use, brachytherapy, stereotactic body radiotherapy, 3D conformal radiotherapy, or IMRT, we have in the literature the idea that you may give second cancer to your patient. And indeed, the global incidence at 10 to 15 years after irradiation is about 0.1, 0.3%. This has been calculated by the Jack Estro group, which is a group devoted to this sort of publication. But then, how can I use this information with my patients? And sorry to be a little bit on this topic, but I have looked to what are the risk of dying in the 30 days after the 30-day mortality after radical prostatectomy. Of course, I'm sure that you have much better result than this group of American surgeons. They have looked at 36,000 patients managed with radical prostatectomy. And look here, the 30-day mortality after radical prostatectomy is again 0.1, 0.3%. So I may use this sort of information telling my patients, yes, you risk to have a second cancer, 0.1, 0.3% incidence at 10 to 15 days, at 10 to 15 years, but don't forget that also radical prostatectomy may have a 30-day mortality, which is of the same respect. And again, this Jeroen has already mentioned, we probably have to wait for randomized evidence. This is the SPGC 15 trial, which is randomizing radical prostatectomy versus primal radiotherapy for these sort of patients. And in the next future, we may have some final results on that. So my conclusion, very quickly, long-term results of radiotherapy plus long-term ADT make it a very nice option for patient diagnosed with prostate cancer. Second, there are two things that may be discussed that I told you, the role of a brachytherapy boost. It really seems that it is a way to get even better results. And the second point that should be discussed is how much ADT. There may be patients that do not need such long hormonal therapy. Third point I want to make, radical prostatectomy is also a very good option for high-risk prostate cancer. And patients should be aware of this. And so if you don't trust comparative observational data, don't forget that randomized clinical studies are ongoing. And in my opinion, what I would like to see is that they will prove that both options may offer the same results. So the choice will be back to our patients. We need multidisciplinary approach, of course, but urologists, you have the first responsibility to mention to your patients about all these treatment choices. And this, I think, will be my final words. Thank you.
Thank you very much, Alberto. I definitely agree that the multidisciplinary team efforts, these are the most important. In fact, there are two questions on the BOLA trial. They have shown nicely that radiotherapy with ADT is synergistic. But now in the modern time, you have much better radiotherapy techniques. Do we still need that ADT, or do we need to do new trials to show it again? What do you think?
Well, this is a very good and very important question for the radiotherapy community. My opinion is that the new radiotherapy we have today should force us to redo all this old-fashioned trial, like the BOLA trial or the RTOG ones. Of course, we know that hormones together with radiotherapy may save lives. We have never shown that hormones can be safely forgot in this setting, but still, I really think that modern radiotherapy may bring something new in this field.
Yeah, but there is something strange here, that with ADT you slow down the cells, and we know that radiotherapy is effective on dividing cells. It doesn't fit. Do you have any idea why this is? That you slow down the cells, you stop them, and then you irradiate, and then the effect is better.
Yeah, there has been a lot of discussion on this topic, and in some situation we have also tried to avoid to have hormonal treatment exactly during radiotherapy in order to prevent this sort of effect, starting hormonal treatment only after radiotherapy. But probably the mechanism of action, the interaction, as you said, the synergistic effect between radiotherapy and hormones is a little bit beyond this problem. So the clinical results are there, and I think we should stick to them.
Because I heard that when you do it neoadjuvant hormonotherapy, your results are worse than when you wait till you start with your radiotherapy. It's
a very good point. Yeah. Indeed. There has been some very recent publication comparing these two strategies, neoadjuvant or pure adjuvant hormones with radiotherapy. And indeed, in the neoadjuvant setting, this seems to be less beneficial to patients. Yeah. How to interpret this is, in my opinion, a little bit complicated. And please don't forget, these are not randomized trials. These are observational conclusions.
Yes, I understand. And one last thing I'd like to know is that now the new way to give ADT is for 18 months, isn't it? That's
yeah. I mentioned that we have some very recent data showing that probably 18-month ADT is more than enough. Of course, the trials showing 2 to 3 years are 20 to 25 years old. So we have very solid data on this. It's probably a little bit too early to switch to 18 months, but still this is what has been published indeed.
Yeah. Well, you nicely showed that there's still a lot to investigate in radiotherapy. Thank you very much, Alberto. We go on with urology. And Michiel Sedelaar is going to talk about radical prostatectomy in T3, so in locally advanced cases. And you're going to share your slides with us, Michiel. Yes.
Thank you, Jeroen. Thank you, Alberto.
Yes.
Thank you, EZU. And thank you, EAU, for organizing this webinar. And thank you, I think 446 participants now joining us in this webinar, which is incredible. Just around dinner time, everybody's enjoying a nice intellectual exercise. Well, for me, also, like Alberto, a very difficult subject, radical prostatectomy for T3 disease. No conflicts of interest for this presentation. And also a little bit, like Alberto said, it's a very heterogeneous disease, but what are we talking about? What are we talking about when we talk about T3 prostate cancer? Of course, you've got the small T3A, you've got the ingrowth in the seminal vesicle, the T3B, but you also have the bulky disease, even going all the way up to an almost or an inevitable T4 prostate cancer. And when you look at the literature, looking up the literature for surgery for locally advanced prostate cancer, it's very difficult. It's almost like apples and oranges again. So because of the many different definitions of locally advanced prostate cancer, and here you can see well-known names, well-known guidelines, but they all have different definitions. So we're looking for evidence. And like Jeroen already said, and like Alberto already said, we're lacking the evidence for randomized controlled trials between radiotherapy and surgery. So what we have to do now is make up a sort of opinion concerning the available literature. The available literature is mostly historic, is mostly retrospective, but still we can learn some lessons from it. This is a little bit of a spoiler alert. The disclaimer at number one is when you do surgery for prostate cancer, 25% of your clinical T2 patients will be upstage to T3, mostly T3A, but also PT3B. And a similar number is downstage from T3 to T2. So apparently it's sometimes even in a clinical setting using your physical examination and your imaging techniques, it's difficult to really identify the T3 disease. Like I said, no standard treatment can be defined in the absence of evidence. But also, and this is also something Alberto said, that locally treatment combined with the systemic one provide a very good outcome. However, about 30% of patients will benefit without adjuvant therapy. So about 30 patients of clinically, locally advanced prostate cancer are able to be cured by surgery alone. You saw that in the Jonio paper. Well, what we know for T3 surgery for locally advanced T3 disease is, well, it's an historic view. And it was usually described in studies where it was part of a multimodality treatment setup. So Donahue and especially Josipovic had large series concerning multimodality treatment, which had an, well, overall, not so worse outcome. It's got a 60% clinical cancer-specific survival at 15 years, 75% overall survival at 10 years. And even if you look at T3, T4 disease, clinical or cancer-specific survival for 87%, overall survival for 56% at 10 years' time. Those are excellent numbers if you look at a very dreadful disease, of course. If you these are patients who have absolutely the possibility to die from prostate cancer. But of course, these are patients from another area, the pre-MRI era, a retrospective analysis, maybe the John West phenomenon of leaving the bad ones out and only reporting about the good ones. We have a very selective memory as surgeons, and we always think about the good, the patients who done so well at my hands of doing a radical prostatectomy in an abominable situation, but we tend to forget, I'm sorry to say, but we tend to forget the bad outcomes of the patients who didn't fare so well. So is this old news? If you look at contemporary view, the most fear you have when you start doing surgery for locally advanced T3 disease is, of course, the fear of not radical surgery, the fear of surgical margins. And I think we have, compared to the historical outcome, we have two options which are available to us, which we can use to minimize the chance for non-radical surgery. And that's the pre-op MRI, and that's the perioperative assessment of surgical margins. perioperative assessment of surgical margins, which has been shown as in the Martini clinic as neurosafe, and a lot of clinics use the same or similar techniques. You decrease the amount of positive surgical margins. You decrease, therefore, the need for adjuvant therapies, and you hope to have improved functional outcome. Well, what is the role of MRI? All of you read the guidelines, and all of you have read that the multiparametric MRI is increasingly used in the pre-biopsy, the pre-surgical setting for prostate cancer. Either directing your biopsies to have targeted biopsies for the diagnosis of prostate cancer, or do a well performed pre-op assessment of the T stage of your prostate cancer. The Pirate score is also very much correlated with the Gleason grading. So a high Pirates score could also mean that it's a high Gleason grading, meaning that it's an high grade, possibly locally advanced, but it is high grade disease. But the role in local staging is limited. And when you look at these two studies from 2019 and 2018, and you skip to the two lines below the headings, so the 99 sensitivity in diagnosing significant prostate cancer, we all know the power of MRI in the diagnosis, but the sensitivity and the specificity for detecting T3 disease for such a very well and detailed imaging technique is actually disappointing. And the same goes for the Jensen study in 2018. Sensitivity and specificity are well below what at least what we hope to achieve with MRI in this setting. Neurosafe or any kind of perioperative assessment of surgical margins. This is a graph which I borrowed from Alberto Briganti, which shows you what the possibility is for Neurosafe. So if you, let's say, go for the blue and the yellow bars on the left side, if you use Neurosafe, your chance for positive surgical margins decreases by 6%. If you have unilateral or bilateral, the numbers are better for Neurosafe than for non-Neurosafe. So indeed, if you use it, you can decrease the number of positive surgical margins. But this is something about the functional outcome using your nerve sparing. Is it indeed helpful for the outcome of continence and erectile recovery? Well, it's still not that, especially when you look at the erectile functions, it's not that well. Kumar had excellent numbers, but if you look at Abdullah and Briganti, two well-known and good surgeons, the nerve sparing didn't reveal any excellent erectile function recovery. And also other outcomes of surgery in T3 disease. This is the series, the contemporary series, small series actually. But if you look at the operative time, the mean estimated blood loss, but also here in the continence, it's very diverse. It's very diverse, although I do think that the continence, using the better techniques by sparing the urethra, the urethra length will improve your outcome, especially on the continence part. Well, you cannot talk about radical prostatectomy for T3 disease without discussing the role of PLND. And I think we need another webinar for about an hour to discuss what is actually the role of PLND, how you should perform the PLND, what are the definitions for the standard, extended, or super extended PLND. But if you look at the guidelines of the EAU, it is well put in the guidelines that you should perform an extended pelvic lymph node dissection during your prostatectomy. Not just on a diagnostic part, but also on a prognostic part, but not on a therapeutic part. So no series has ever shown that doing a pelvic lymph node dissection will improve the outcome of your surgery. Well, here you see a nice image of the pelvis, the hemipelvis. What is a extended pelvic lymph node dissection? Those are the areas for the obturator nerve, the internal iliac artery, and the external iliac artery and vein. So this more or less triangle should be considered a extended pelvic lymph node dissection. If you go higher up or more to the sacrum, you go to the super extended pelvic lymph node dissection. Fossati had a nice study on PLND during radical prostatectomy, and this is one of the studies stating that it didn't improve the outcome for survival, but it is accepted that an ePLND provides important and prognostic information. And here again, if you have the area of the external iliac artery, the internal iliac artery, and the obturator nerve, about 94% of patients will be correctly staged in these settings. Of course, we talked about the role of MRI. I'm not going to talk about the role of PSMA, at least not in a detailed fashion, but we do think that PSMA will be able to improve these numbers in the future. Maybe even if you have a negative PSMA scan, you don't have to do a PLND, but those are answers we're still waiting for the validation of the PSMA in different surgical settings. What about the number of nodes removed? Anything above 15 is considered an adequate pelvic lymph node dissection. The number of nodes is also very dependent on the pathology and the way the specimens are processed. But anything about 15 nodes should be considered a nice pelvic lymph node dissection. Well, talking about a sort of proposal for surgical protocol, anything you do before surgery, do not offer ADT. There's no evidence of benefit to do ADT before surgery. There are trials ongoing, and pre-op MRI is definitely mandatory to do before assessing on such a surgery for locally advanced disease. At radical prostatectomy, have a tailored approach based on imaging and frozen section, and think about the extent of your lymph node dissection. And after surgery, tailored use of adjuvant therapies, which will be discussed by Jeroen a little bit later on. One small thing about adjuvant radiotherapy, not just the outcome, but who are at risk for the need of adjuvant radiotherapy. But the predictors of relapse are T3B, T4 disease, Gleason grading 8, 9, 10, positive nodes during your pelvic lymph node dissection, and a decipher score of larger than 0.6. We don't use the decipher in Europe, but in America it's used quite often. So after 14 minutes and 41 seconds, I have two recommendations. One, radical prostatectomy. Offer radical prostatectomy to highly selected patient, tailored approach, well-informed patients and well-motivated patients. And the extent of your pelvic lymph node dissection, well, do perform a lymph node dissection and do not perform frozen section of the nodes during radical prostatectomy. It will not change your procedure. And I think, Jeroen, that was my last slide. Yeah, because this one you already saw at the beginning. So use an individual approach. When you think about radical prostatectomy, think about the fact that about 30% of patients will be cured with monotherapy, but 70% will have the need for adjuvant treatment. And use an MRI upfront and intraoperative assessment of surgical margins during the surgery. Okay, I think that's...
Okay. Thank you very much, Michiel. That's a clear message. About the frozen sections, you showed that you should not do a frozen section of the lymph nodes. I agree on this. But the neurosafe, that's frozen section during surgery. And does it really change your way of operating? Is it anything we should do now?
Well, the jury is still out there. I think it's if you think about neurosafe in preserving erectile function, that's definitely not proven. If you think about neurosafe as sparing your positive surgical margins, I think that's proven. Well, and we do know that surgical margins are correlated with relapses. So in that sense, especially with these high-risk patients, I would consider doing during frozen sections, or at least something equivalent to neurosafe during surgery.
Okay. And you were quite clear on MRI. Eh? You said you have to do that in every patient. You should do that before surgery.
Let's say, when you are in a diagnostic trajectory for a patient with an elevated PSA, it's recommended to do an MRI.
Yeah. Okay.
Those patients, some of those patients will be operated, so you already have your MRI. And I think the MRI will guide you in your surgery, but be aware that the fact that small T3 disease will not be visible on an MRI. Mostly the T3B will be visible on MRI, but don't count on it that when the MRI says it's a T2, it's definitely a T2. That's not true.
I agree on this. And there is another thing that you could measure, the MUL, the mean urethral length. Is that something you do in your hospital? Is that...
No, we don't do that in our hospital. I know that our colleagues in Amsterdam, the Dutch Cancer Institute, are doing it. I haven't seen the real evidence yet, but there's something to say about urethral length and the chance for incontinence post-operatively. Yeah,
but it's not really definite yet. Eh? I agree that it's not easy. Let me see. There was one more question on the PSMA. You showed yourself that the PSMA is something that might be useful, isn't it? Or is it, did I understand you right, that you say, well, you should do this or you should not do this?
Well, again, the jury is still out. It's an unvalidated imaging technique. We tend to use it a lot. Me, myself, will use it almost in any high-risk patient preoperatively, but also to get a sort of assessment of the chance for positive lymph nodes. But be aware, it's still non-validated. And
we have done in the Netherlands a trial on should you do a lymph node dissection, yes or no, and then we know that the specificity of the PSMA is high, but the sensitivity is low, so you still have to do a lymph node dissection. I think that's what we know up to now.
It doesn't say there's nothing going on there. That's true.
No. Okay. Well, thank you very much. I will go on with the last part of our evening. Let me see whether it's working. Yes. Can you see my? Do you see my slides? Yes. I'm going to talk about the adjuvant therapies following radical prostatectomy, and these are my conflicts of interest. What are we talking about? It's radiotherapy, hormonotherapy, chemotherapy, or combinations, and there's quite some data known. But first of all, the positive margin. a surgical margin is, well, is an independent risk factor. I agree on this. And a margin status is positive when there is tumor cells, when these are inked. And that a positive margin in itself is not an evidence of extra prostatic extension. And there is a nice graph that here, that's a T2 that's within the prostate. That's logical. But you can have a T2 with a positive margin. When we as urologists cut into the prostate, then you can have a positive margin on a PT2, but no extra prostatic extension. This is a T3. There is extra prostatic extension by definition, but not a positive margin. In here you have them both. So I think this makes it a bit clearer. Here we have a small tumor deposit with ink on it. But when you look at this flap, that flap should in fact cover here the prostate, and then it would be negative. So I think this is positive, a positive surgical margin, but clinically not important. And here is another positive one. Here the urologist just did cut into the prostate, and there is ink here. But again, this is not a clinically significant positive margin. So that's why not always positive surgical margins are important. And here this is about 11,000 patients, a quarter were positive surgical margins positive, but it's not an important factor in the multivariate analysis. So positive surgical margins in itself might not be important. But I think you have to operate, of course, you have to operate very nice and you have to do it a good surgery, but then it's not all that it's not all about positive surgical margins. So what's your natural history of patients with a rising PSA? These are the so-called pound data, the pound data, 2,000 patients, no neoadjuvant therapy and no adjuvant therapy, only when it was M+. And then of these 2,000, 300 developed a rising PSA, and then 100 of these, so 1/3 developed M+ disease. And the time between the elevation of the PSA and M+ is 8 years, and then another 5 years that patient die. So these are the data from Baltimore. So you have 13 years to go. So don't get too nervous about a rising PSA. And then they looked a bit further, and then when you have a high Gleason score, the patients do worse. And when you have a early recurrence, patients do worse, and when the doubling time is short, of course, also patients do worse. In the guidelines, the biochemical recurrence is related to some factors, and you see here positive surgical margins. Well, it's here for distant metastasis. It is there also a high ESUB score, a high PT category, short doubling time. But the most important thing and interesting is that we can stratify patients now between a low risk of a biochemical recurrence and a high risk of biochemical recurrence. And the low risk are the patients that have a long PSA doubling time post-surgery and the low ESUB score. And when you don't have that, then you have a high risk. And that has been validated in a European cohort, mostly from Hamburg. And they indeed see that metastatic progression and cancer-specific mortality are related to the group you're in, the high-risk group and the low-risk group. So what should we do with the PSMA or with imaging? We just talked about the PSMA for the lymph nodes, but when you have a rising PSA after radical prostatectomy, and that's very, very low usually, that PSAs, a bone scan or a CT scan are not very sensitive. So the advice is to make a PSMA scan when you have the availability of this. And then you should do it when the PSA is still very low. So above 0.2, already make a PSMA scan. That's the advice. And when you don't have it, then you can make another PET-CT or a choline when the PSA is a bit higher. So what to do, adjuvant or salvage radiotherapy? Well, adjuvant radiotherapy is immediately after operation when there is a extracapsular extension or positive surgical margins or seminal vesicle infiltration. And salvage is that wait to see when the PSA is rising. And there are a few randomized trials done. This is another BOLA trial. These were the risk factors, of course, as I just showed you. But this is the problem. Undetectable post-surgical PSA was not required. So it might be that patients with positive lymph nodes were also in here. They were randomized between radiotherapy and watchful waiting. So wait until the PSA is rising. And this is what's coming out. And this is the most important, I think, is the overall survival. There's no difference at all. So early start with the radiotherapy or just wait, overall survival, no difference. There was an American trial done, exactly the same, but there was a difference. There was a difference here in overall survival, for example. There was a clear difference, and that's strange. Why was the bullet trial negative and this one was positive? And then you have to see to the patients groups, the post-operative irradiation, the survival was 74% and 77%, but there was a difference in the wait and see group. So it was not, the irradiation had the same effect, but there was a difference in the wait and see group. And that's the difference in follow-up and the how you do your imaging. This is a German trial, and these patients need to have a post-operative undetectable PSA. That's interesting, I think. This is the best trial. And there you see that there is a progression-free survival difference, but not in overall survival. Overall survival is the same in this trial. And the last trial is from Finland, and they did, in fact, a bit the same. And again, the overall survival is not different. So can we conclude anything from the immediate versus watchful waiting? Well, there is a better 10-year biochemical progression-free survival, but I always say to my patients, you don't die from PSA. There is no overall survival benefit, except in that SPOC trial, but that has to do with the control group. We know that early post-operative radiotherapy is associated with worse functional outcomes. I didn't show them, but for incontinence and impotence is higher when you irradiate very early. And in 3 out of the 4 trials, an undetectable post-surgical PSA was not required. So what about adjuvant versus early? Maybe there's the answer. And there are 3 trials done. The Radicals trial, randomized between adjuvant radiotherapy and salvage radiotherapy. And here you see the biochemical progression-free survival, no difference at all. There are no overall survival data yet of this one. This is the Radicals trial. This is another trial, the RAVES, biochemical progression-free survival, no difference. In fact, it's about the same type of trial. Then we have the JETUC 17. These patients were also the same as the Radicals at the RAVES, but they did get 6 months of triptorelin, so an LHRH agonist. And again, no difference in event-free survival or overall survival. Was a meta-analysis done? This is the artistic analysis, and there you see when you have all these 3 trials, there's no difference at all. So that means that adjuvant or salvage irradiation might give the same effect. And what to do then? I think then you have to wait to give salvage radiotherapy. Hormonal therapy, this is the EPC program. Then it's only, that's bicalutamide added to all different types of therapies. And there it's only locally advanced disease and radiotherapy. There is some effect of bicalutamide. It is a systematic review, and it says, well, don't give hormonal therapy alone. Maybe only in the highest disease progression groups, but don't give hormonal therapy alone. Chemotherapy, is that an option? Well, this is a nice Scandinavian trial that added docetaxel alone after radical prostatectomy, and there is no difference at all. So here, again, this adjuvant therapy, and that's only docetaxel, is not effective. Are there any combinations that are useful? I think this one is an interesting trial. It's a Shipley trial, phase 3 trial, randomizing adjuvant radiotherapy with or without bicalutamide. It took about 10 years to see a difference, but then there is a small difference between the placebo group and the bicalutamide group in favor of bicalutamide. So it seems that combining is useful, but when you break down the groups, then you see that it's It's only useful in the higher PSAs. And now we tend to start PSA or irradiation already at 0.2. Then I think the addition of bicalutamide is not very effective. Kerry did a trial that combined the radiotherapy, adjuvant radiotherapy, with goserelin, so also an LHRH analog. And there is a small difference in metastasis-free survival, but overall survival, I think that's the most important, is still no difference. Our guidelines say that you might combine radiotherapy with ADT, but I think the jury is still out. Should you add then chemotherapy next to the radiation therapy and the LHRH analog, and that's midoxantrone in this case? Well, there's no difference at all. So I don't think that addition of chemotherapy here has anything in favor for the patient. So what do the guidelines say? When there's a low risk of biochemical recurrence, don't do anything, just monitor. You can give radiotherapy when there is a rising PSA. When there's a negative PSA scan, don't delay any radiotherapy. And when you just want to irradiate, just do it and don't wait for a certain threshold. So what's the conclusion? Adjuvant therapies, radiotherapy, yes, but then early salvage. I think that's better than too early radiotherapy adjuvant. Should you give hormonotherapy in combination with the radiotherapy? I think there's some doubt, and wait for longer follow-up. Chemotherapy or chemotherapy with ADT you should not give. So this is what I wanted to tell you. So there are some differences still, and I think radiotherapy is interesting, but do you agree with me, Alberto, that you should give it in an early salvage fashion and not adjuvantly?
Yes, I think that for the time being, we have enough evidence showing us that early salvage is better than adjuvant. You may also mention that the toxicity, as you said, in these 3 recent trials, Radical Raven, our JETUB trial, the toxicity of early salvage is much less than the one of the adjuvant setting. So in my opinion, there is no reason to go for immediate adjuvant radiotherapy. You may wait for a rising PSA.
But the comment on these trials is that there are not so many high-risk patients in there, and the follow-up is a bit short. So I'm rather blunt in my conclusion. But can we really say this? Should we not wait a bit longer for longer follow-up, or shall we just? I mean, what we do in my hospital, we do early salvage. We don't give it too early because I think the functional results is also a problem. But do we really already know?
Well, it will be interesting to see the results of these trials when the high-risk group will be identified and published. That's indeed true, but this is what we have today. So I really think we have to stick to the evidence. Of course, you are right. I would have preferred to have much higher prognosticators in this group of patients after radical prostatectomy. We all agree that there is no role for immediate adjuvant radiotherapy for a Gleason 3+4 with negative margins, no infiltration of seminal vesicle. This is a patient that probably will never need any sort of treatment. And even if his PSA will be rising, this is also important to identify. But indeed, this is what we have up to now. But if I may, there is the role of PSMA in this setting, which you mentioned, which is to me, I don't know what Michael think about this, but I really think that this will make an important, will be an important play changer, game changer, because PSMA in this setting may totally change our way of treating those patients. What do you think, Mike?
Yeah, I totally agree because, well, only from a casuistic point of view, you already have your patients where you have a PSA of 0.2, 0.3, you do a PSMA scan. You definitely think there will be a local recurrence, and suddenly you see a lymph node, which is positive. And I think using PSMA in that setting is maybe the less controversial one to using the PSMA scanning. And I definitely agree with that being a very important addition to our diagnostic pathway. Much more than using PSMA in an early setting, because we don't know yet. So
I'm just looking through the Q&A, and that's the most difficult question you can ask is what to do with positive lymph nodes. And I find it always very difficult. That's the most difficult part in urology and prostate cancer, what to do with positive lymph nodes. And then when you see this on a PSMA scan, is it then still locally advanced, or is it already metastatic? What to do?
I think there's no answer there.
Okay.
We in our hospital, we say that if you have maximum to 4 localized lymph nodes, let's say close parameter, small pelvis to the prostate, we still consider that as an oligometastatic disease, for which we do a lymph node dissection and a radical prostatectomy, or a lymph node dissection, radiotherapy and hormones.
Yeah, I didn't talk about that because
anybody being cured in that sense. But
no.
we have an aggressive treatment for let's say minimized metastatic disease.
Oligometastatic disease is very difficult, and that's amazing. But we have to look for that. But I didn't talk about that. The last question to Alberto: when we irradiate, all the trials I showed are for local, the prostate bed only. And should we also irradiate the lymph nodes?
Yeah, this is a very good question. So I will tell you what I do in my clinical practice. If I have a patient with a rising PSA which has never had any treatment of his lymph nodes because he never had any sort of extended lymph node dissection upfront, I tend to irradiate his lymph nodes. If he already had some form of lymph node dissection at the time of the upfront surgery, I will not. But this is exactly, as Michael said, the setting in which I think PSMA will totally change my way of thinking to those patients. Because in this situation, a PSMA will give me arguments in order not to treat the pelvis in any case, I guess.
Okay, thank you very much for your questions. Thank you very much for both of your nice presentations. I think we had a nice hour talking about locally advanced prostate cancer. And as you felt already, we can talk longer and longer when we include the lymph nodes, when we include all the other types of HIFU, et cetera, the focal therapy, then we can talk about one day. I hope you liked it. We have still more than 420 participants, so they're kept with us. And thank you very much for all your attention. Have a nice evening and a nice dinner for later on. And I hope to see you soon somewhere. And I hope to see you in live. Thank you very much for your attention. Bye-bye.
Thank you. Bye-bye.